cervical range of motion, and its impact on shoulder and elbow injuries in baseball pitchers. Here's an overview. We're going to take a look at two studies, Devaney et al. And Bullock et al. And we're going to highlight the differences in the studies, in the outcomes, and their interpretations. And then we're going to take it a step further and try to provide some clinical strategies for treating pitchers with cervical mobility deficits. But I also want everyone to think along the lines of just shoulder patients that may also have neck issues as well, or just clearing the neck joint when somebody comes in with a shoulder issue. On some of the scripts from some of our referral sources, you'll often see cervical range of motion for the shoulder patients that come in. So I want us to pay particular attention to what we could actually do for some of these people. First study is Devaney et al. And let's just kind of go through the general idea of this article so that we have a better understanding of it and can begin to critically think how we can use this in our everyday practice. So the purpose here was to investigate the relationship between cervical range of motion and shoulder and elbow injuries in college baseball pitchers over a season. We'll notice in this next one, it's professional baseball pitchers over a season. So that can kind of help us distinguish between the two studies as well. The hypothesis was that reduced neck mobility increases the risk of injury. We had 49 college pitchers with the mean age of approximately 20 years old. They were screened for neck and shoulder injuries and mobility preseason. Injuries and pain were tracked throughout the season. They were tracked using the patient-reported outcome of the functional arm scale for throwers. That was new to me, so I'm definitely going and looking that up. And they use this to gauge self-reported pain and disability. Primary findings that what they found was that reduced cervical flexion, less than 64 degrees, and upper cervical rotation, so C1, C2, atlantoaxial, was less than 39 degrees, and they tested that through the cervical flexion rotation test. I think I've shown quite a few of you that specific test and how to treat it with a muscle energy technique. And then what they did is they found those that had the less than 64 and the less than 39 degrees were associated with an increased risk of shoulder and elbow injuries and the higher patient-reported pain on the FAST measure. They also found players with reduced neck mobility experienced shorter playing times before they became injured. The study also showed additional risk factors of a body weight greater than 86.9 kilograms, around 190 pounds. They said that the heavier players had a 10x higher risk of self-reported pain and disability. They think this is possibly due to the increased forces during pitching. We also found that side-to-side difference in shoulder range of motion, external rotation measurements differences greater than 12 degrees were linked to higher pain risk, but were less conclusive statistically. They also found the timing of the injuries. Most injuries occurred early in the season, within the first 10 weeks. Some biomechanical considerations: neck mobility affects head stability during the pitching motions, late cocking and acceleration, and the follow-through phases. They found that compensatory cervical movements, for example, like mid-cervical rotation or side bending, may impair neuromuscular performance and predispose pitchers to injuries. Also, we want to think about biomechanically restrictions in the proximal kinetic chain elements, again, like the cervical spine, may impact distal joint function. The utility of measures here: for the cervical flexion and rotation test and cervical flexion, they both had a high sensitivity and negative predictive values, which made them effective for screening pitchers and their risk of injury. Preseason GH mobility was not significantly different between the injured and the uninjured group, highlighting the values of assessing neck mobility. So some of the strengths and limitations within this study. This was the first study to explore neck mobility as a risk factor for shoulder and elbow injuries in pitchers. And then there was a really good injury definition, including both time loss injuries and patient-reported outcomes. Limitations: small sample size, so it may not generalize to other age groups, other regions, or competition levels. And then there really wasn't a lot of data on the workload measures, such as practice pitches as well as velocity. So some of the key takeaways for understanding and managing similar patients, some of the biomechanical considerations would be that neck mobility affects head stability during the pitching motions, late cocking, acceleration, and follow-through phases. Again, the compensatory cervical motions at the mid-cervical and lateral flexion may impair the neuromuscular performances and predispose pitchers to injuries. And then restrictions in that proximal kinetic chain may impact distal joint function. So we should think about including cervical range of motion tests, including the C1, C2 in preseason evaluations or just in our everyday evaluations. Pay attention to patient-reported history of pitching with pain, or in our patients, any other prior injuries to the neck. Could be motor vehicle accident, concussion, whiplash, anything like that. Recent falls in the geriatric population. And then prevention strategies. So address neck stiffness proactively with mobility and flexibility exercises, say in our post-operative neck patients, or in somebody that you know or that you are treating and has a forward head or hyperkyphosis. And then we could also consider some type of weight management or conditioning program for our heavier patients or heavier athletes. Intervention insights. Early intervention during preseason screenings may reduce injury risk, which is obvious, and the sooner that we can treat and notice these things, the less likely they are to get injured. Could be your person that goes to the gym and works out all the time. They could have some cervical things going on if they're having shoulder pain. Patient education, that's always important, right? So we need to be able to explain the importance of neck mobility for our pitching mechanics, injury prevention in these sports-minded patients, but also for our shoulder patients and the role of that theory of stability, mobility, the alternating stability, mobility joint sections, and how a upper cervical stiffness can lead to hypermobility at the mid-cervical level, which then can lead to further on down the chain, right? Obviously, we want to emphasize adherence to the preventative exercises in all of our patients and the potential impact of their posture on where their pain is coming from. Study kind of led me down a rabbit hole, and that's why I pulled this next study by Bullock et al. And let's just kind of review it, and then we'll compare the two, and then find the clinical implications, and kind of go down that road. So the purpose of this particular study was to assess the generalizability of neck range of motion measures as a prognostic factor for arm injuries in professional baseball pitchers. The hypothesis was that neck range of motion deficits, particularly differences between dominant and non-dominant sides, predict a higher risk of shoulder and elbow injuries. This study design had 88 minor league baseball pitchers from a single Major League Baseball organization. Time frame, it was from February to September of 2023, so it was an entire season, including spring training. The data collection, so they did this during preseason measurements of neck and shoulder range of motion. This one, instead of using a goniometer, they used digital inclinometers. Injury and exposure tracking throughout the season. They controlled for the variabilities like pitching roll, appearances, innings pitched, fastball velocity, and shoulder range of motion differences. So they try to control for all of those. And what they found in the study for these particular athletes is that their flexion averaged around 64 degrees with a standard deviation of 10 degrees. Extension, they found it at 69 degrees with a standard deviation of 11. Dominant rotation, they found it at 77 degrees plus or minus 9. And then non-dominant rotation was 79 degrees plus or minus 8. And so they found the differences in dominant versus non-dominant was -2 degrees. And that standard deviation again there was 9 degrees. So the injury outcomes, out of those 88, total injuries were 20, 9 were the shoulder, 11 were elbow. Injury rate was about 1.3 per 1,000 exposure days. For every degree increase in the difference between dominant and non-dominant rotation, there was a 4-fold increase injury risk. That's quite a bit right there. The other observations is that there was no prognostic value found for the cervical flexion rotation test or lateral flexion differences, which is a little different than that first study that we saw. And then dominant side neck rotation deficits correlated with altered pitching mechanics, which in particular in this article they discussed the gaze maintenance during pitching phases. So that's something else to consider with some of these athletes and kind of leads us down the road of our concussion patients and looking at upper and lower cervical and also working on some of the VOR, the vestibular ocular reflex, and the gaze stuff that we work on so heavily with our balance patients and concussion patients. So clinical implications in screening, and we could use this in screens that we do, free screens or any other screening evaluations, include the dominant versus the non-dominant neck rotation. Focus on rotational asymmetry as a key risk factor. If we're talking about mechanics and rehabilitation, and if you have athletes, we'd want to make sure that we're aware that reduced neck rotation can lead to compensatory trunk or scapular movements, increasing on the stress on the shoulder and elbow. So I think that's important to notice the why behind it. And then address proximal chain deficits with specific interventions, including range of motion restoration, neuromuscular retraining, muscle energy techniques, all the stuff that we do every day. And then similar to the other, injury prevention. So target interventions to improve neck rotation, symmetry, especially in our older generation folks or especially in our pitchers if we're working with an athlete. And then something else to consider is integrate posture, which we typically do, and gaze stabilization exercises into training programs for our athletes. And we used to do this a lot with a lot of our higher end athletes where we'd have them doing multitasking where they'd be naming colors or looking at cards and telling us the numbers on the cards while they're also doing other activities. We do that with our concussion patients where it's dual task training. So be thinking along those lines to make your treatments more engaging, more sport specific, or more life specific. Strengths and limitations, prospective cohort design with the detailed range of motion and injury tracking. And they did well for they controlled well for the critical covariabilities like the pitch velocity and the role of the pitcher, if it was a middle reliever, an in-game reliever versus a starter. The limitation, again, it was kind of a small sample size of 88. Single season data was all that was studied there, so it kind of limits the long-term generalizability. The range of motion was only measured during preseason. Mid and late season changes were not accounted for, and that lacked some pitching biomechanics data. So the conclusion here is from this study is that neck rotation asymmetry is a significant risk factor for arm injuries in a professional pitcher, reinforcing its role in injury prevention protocols. All right, so moving on here, key differences between the studies. The population characteristics I thought was very important. So one focused on professional baseball players in the minor league, which they have a higher level of training and conditioning versus the college kids, and they likely have access to advanced medical care, manual therapy, which could kind of mitigate some of those range of motion limitations. And then Devaney et al., his was the college level pitchers, likely less exposure to comprehensive injury prevention programs at this point in the game, and range of motion deficits may have had a greater direct impact on shoulder and elbow injuries. The injury definitions, which I spoke about earlier, for Bullock et al., defined injuries as requiring missed practice or games and medical attention, focused on time loss injuries. And they looked at the hazard ratios for an injury over the season. And Devaney et al. Included broader outcomes such as self-reported pain and disability. That was through the FAST, so not necessarily time lost due to injuries. And they may have captured subclinical issues related to cervical range of motion deficits. So the sample size and statistical power, the Bullock et al. Had a larger sample size, but only 20 injuries. So it was potentially underpowered to detect the subtle correlations. And Devaney et al. Had a small sample size of 49, but a higher relative injury rate and focus on broader metrics, potentially amplifying the associations. And then we had the range of motion measures and testing. So the consistency, Bullock et al. Used a digital inclinometer and a single experienced examiner. The cervical flexion rotation test values may have been influenced by better measurement precision or the variability across clinicians. In Devaney et al., the findings could have been more influenced by examiner technique or less stringent measurement protocols, leading to stronger observed associations. So we also found from a compensatory mechanism that professional pitchers had better trunk and scapular mechanics. So that kind of buffers the range of motion deficits. If any of you guys have gone through the Titleist Performance Institute certifications and the On Base U certifications, it discusses that these professional athletes are just better at compensating. So that is something that really stood out to me between the college versus these professional baseball players. And I just kind of remembered that from my previous studies. So, clinical implications, biomechanical differences and contextual differences, the performance level and physical demands. Professional pitchers likely have better developed compensatory mechanisms to handle the subtle deficits in cervical range of motion without a significant downstream effect. Collegiate players may rely more heavily on cervical range of motion to maintain optimal mechanics due to less efficient compensatory strategies. Think about the kinetic chain integration. Professional pitchers have superior trunk, scapular, and lower extremity mechanics may buffer the effects of the cervical range of motion deficits, whereas the college players might experience greater kinetic chain disruptions, amplifying the impact of cervical dysfunctions on shoulder and elbow mechanics. Finally, gaze stability and pitching mechanics. In professional pitchers, subtle rotation deficits may not significantly impact their ability to maintain their gaze stability during pitching. Collegiate players may struggle more with this gaze compensation, increasing the stress on the distal joints. Treatment strategies that you can do during your screens and your evaluations. Always think about that alternating stability versus mobility theory. So look at the upper cervical testing, and that would be CO and C1 testing for flexion, and then C1, C2 for the rotation at the atlantoaxial joint. And then consider going down to the lower cervical region and look at C7T1 and consider a 4 plus at that particular position. When looking at range of motion for the cervical spine and testing the lower cervical, I know some people use gonies. We have used bubble inclinometers as well in the past, and when we do some of our pre-employment screenings in the past, they've also asked us to use the bubble inclinometer for its accuracies and to take out some of the compensatory movements. And so you put one of the bubble inclinometers on top of the head, and then you put the other at C7, and that's for all your side bending as well as your flexion and rotation. So you subtract the C7 one from the top of the head, and that'll give you your cervical motion there. You always want to assess the thoracic rotation. I feel like that's really important. And so the best way that I have found to test that, and it's actually through the TPI way, and that's you're seated, you have your knees crossed, and your feet are crossed and your knees are touching. So if I crossed my right foot over my left, I want to maintain my knees touching. And then since my right foot's over my left, I'm going to rotate through my thoracic spine to the right. And as I do that, I want to take a measurement there, and I also want to ask the patient if one feels easier than the other. But you also want to add your cervical flexion and rotation to the opposite clavicle in this particular test, and that actually is very similar to cervical flexion and rotation. So that is a test that they do in TPI. So I feel like that is a important test for our athletes here to look at their thoracic rotation in combination with their cervical flexion and rotation. Looking at the total arc of shoulder motion, left versus right, usually 5 to 10 degrees is what we found to be clinically significant. And then when you're looking at GERD, you're looking at the glenohumeral internal rotation deficit, and you're looking at approximately 20 degrees of difference between the dominant and the non-dominant, can usually be of significance. And then always incorporate posture, your neuromuscular re-education for proper posture, and then adding more gaze stability activities for these athletes. Elaborate on that last point on the last slide, and that's about the gaze stability, because the others we typically do in our everyday treatment. We typically look at the shoulder range of motion, we look at GERD, we look at total arc of motion, we look at posture, we look at the alternating stability versus mobility theory. We we need to do a better job at looking at COC1 for that upper cervical flexion, and we need to do a better job at looking at C1 and C2, and that's that cervical flexion rotation test. Typically, those are treated through the muscle energy techniques. And that kind of brings us to this vestibulo-ocular reflex, because during those muscle energy techniques, you actually are using the eyes as part of that muscle energy technique, because some of the nerves off of the eyes actually come back and insert into some of these upper cervical muscles. So that's why it's important to also consider this vestibular ocular reflex and moving forward there. So the VOR purpose is to improve your eye stability during head movements. How do we do that? We're very familiar with this with our balance patients or our vestibular patients, our concussion patients. You hold a small target, say a letter on a card or a pen at eye level, and you move the head side to side or up and down while keeping the target in focus. You can gradually increase the speed while maintaining that visual clarity. So progressions of that, right? You can add background noise. You can add different visual patterns, different things going on in the background. You can perform it in different postures. For our balance patients, we often do that in sitting and progress to standing. But for our athletes, we could do that in a split stance. We could do it while also balancing on a single leg or on an unstable platform. The other thing we do is gaze shifting with cervical mobility. That's basically where you combine the eye movement with the neck flexibility, the cervical flexibility. So you start seated or standing, focus on a target in front of you, and now you're going to rotate your head to one side while shifting your eyes to maintain fixation on that target. And then you can return to center, then repeat on the opposite side. Again, you want to progress this by performing during, let's say, for an athlete, you can maybe do this during a light pitching drill, or maybe under dynamic conditions, you could do it on a balance board or a BOSU board or an AirX pad. Single leg balance with head movement. We've always done the single leg balance, where the old thought process is always the contralateral hip for these overhead athletes. So we've always done single leg balance, but now we're going to do single leg balance with head movement. So the purpose is to improve the postural control while also engaging cervical motion. So you stand on one leg, focus on a stationary target, move your head in various directions, rotation, flexion, extension, all while maintaining focus on that target. You can progress this by closing your eyes briefly or performing it on an unstable surface, such as, again, the flat side of a BOSU. You got reactive balance training. So you can stand on a foam pad or a balance board, catch a ball tossed at various speeds and directions while keeping the head stable. I also do this sitting on a stability ball and having a ball come up and over their head, and this is almost like a deceleration for throwing activity, and then we can try to move that into standing as well. Sport-specific drills, so visual tracking during pitching mechanics, so simulate that pitching motion while focusing on a target at the strike zone. Partner provides feedback to kind of ensure that the gaze stays fixed during key phases such as stride, cocking, and follow-through phases. You can do rapid target changes, so you can use multiple visual targets around the room, call out a target number or letter during simulated pitching motions. Pitchers can then shift their gaze to the new target without losing their balance or their posture. So there's a lot of different things that we can work on here to incorporate gaze stability into a sport specific type uh, atmosphere. So treatment strategies, cervical strength and mobility. Strengthening, you can also add that in where you can take a resistance band uh, and do cervical exercises with that. You can do isometrics with it. You can do your deep flexor endurance activities where you do your chin tuck head lift. Uh, there's a lot of different movements that you can do with the cervical, and there's even some new devices out there where you lay your head down and it's got some resistance bands and you actually work on that rotation. For mobility again, the gentle neck stretches in all planes, levator exercise where you actually do some flexion and rotation there. That's going to get a lot of that lower cervical, mid-cervical area. But again, don't forget your CO, C1 for the rest of the flexion, and then don't forget your C1, C2 for rotation. And there's some muscle energy techniques where we incorporate any type of impairment of range of motion and try to increase that range of motion. You also have a C7T1 clearing, which is very important to kind of unlock that C7T1 area. You got your thoracic extension over the foam rollers. You got all your different types of thoracic rotation drills from a quadruped thread the needle to a high plank thread the needle to the kneeling at the wall windmill series. And then just combining thoracic rotation and cervical flexion and rotation uh, as part of the treatment pattern so that it can mimic the pitcher throwing. Now, again, if these are some a post-op patient or something, then maybe it's not throwing. Maybe it has to do something with their work, and we want to make sure that they have that type of range of motion so that when they go back to work or go back to working in the garden or out in their tool shed, whatever, that we are able to duplicate some of those movement patterns. So treatment strategies, neuromuscular training, that's that. I always think of this as like wearing that laser that we have for concussions where so it's similar to concussions, right? And you do some of that visual tracking and you can stimulate the visual processing, and now you can add dynamic conditions. So uh, let's think of like you can warm up maybe by starting a session with some simple gaze stability exercises. Functionally, we can then start incorporating different drills into the pitching mechanics in practice, and then progress gradually moving from a static controlled exercise to dynamic sport specific exercises where these methods can enhance the gaze stability and reduce compensatory movements, ultimately potentially lowering injury risk in pitchers. So wearing that laser while they're kind of going through different portions and making sure they stay focused on, let's say, the strike zone or the high portion of the strike zone or the low portion of the strike zone. And then you also have they have like interactive light boards. Something that you could probably think of is using those blaze pods and being able to track things with your eyes, and that would help to improve your reaction and your coordination. So integrating these insights into your practice, these collegiate pitchers, they focused on early detection and correction of the cervical range of motion deficits and emphasizing a comprehensive kinetic chain assessment. So again, that's going for me on that alternating mobility versus stability theory and kind of going down the chain there. Professional pitchers, they targeted compensatory mechanics while maintaining cervical mobility. You want to incorporate the advanced tools like some strobe glasses or the blaze pods or the lasers and add reactive drills for the higher level athletes. Because as we know, the higher the level of the athlete, they are just able to compensate better than the lower end athletes. As we conclude here, cervical range of motion is a critical factor in injury prevention for pitchers, right? But should we also consider it for other overhead sports? What about tennis or volleyball or swimmers or position specific, such as a quarterback? And then we also want to think vocation specific or just ADL specific as well. The treatment and prevention strategies must be tailored to the athlete's level of play. Knowing the level of the athlete also shows how well their body can compensate. So as they get higher level, become a higher level, their body's going to be able to compensate better. And then always, future research should explore the long-term effects of these interventions on injury rates. This just kind of reminds me of like sports metrics or the FIFA 11 to help reduce injury risk for athletes that play deceleration sports, and they have found that those 6-week programs can significantly reduce injury rates. So I hope this helps everyone in looking at shoulders just a little bit different and considering cervical range of motion and upper cervical mobility for adding that as a treatment program for some of your overhead athletes. Thanks for everybody's attention, and good luck with treating these types of patients.